Thank you, Anna. And now we will invite Dr. Peter Hadden. He will be presenting on utility of multimodal imaging in retinal diagnosis. Dr. Peter.
Good morning, and thank you. My slides? Yeah, thank you. So multimodal imaging is, of course, the use of more than one technique to complement each other. So first, let's look at photography. So photography has many uses, one of which is remote diagnosis, for instance, in diabetic photo screening. I also, for instance, run a virtual multimodal imaging tumor clinic in which I review the images of patients without having to see them to rule out benign lesions such as this nevus, which is seen here to have no fluid on the OCT and relatively dark on autofluorescence. Adding a red filter, it has gone. We also have wide field cameras, of course, that have much improved our ability to visualize the periphery and large lesions such as this tumor. Adding a red filter can image choroidal lesions better, while red-free photography is especially useful to highlight red-colored lesions such as hemorrhage and diabetic retinopathy. Many modern cameras, of course, also do fundus autofluorescence, which detects lipofuscin and other fluorophores, and which also enable it to detect subretinal fluid, for instance, in this peripapillary uveal melanoma. It also can be used to follow diseases that affect the RPE, such as serpiginous, which you can see here followed very easily with autofluorescence. And chirpies are characteristically very dark, and again, obvious on autofluorescence. Photography can also allow the sharing of problem cases, of course, too. In the South Pacific, we have a WhatsApp group the Pacific Island doctors can use to get advice from Australian and New Zealand ophthalmologists, and I can also ask colleagues overseas for advice on some of my cases. And finally, serial photography can sometimes clinch the diagnosis, such as in this uveal melanoma. Of course, we can't forget fluorescein angiography as well. Another form of imaging we use is OCT, of course, which is used in the retina mainly in two ways, either to map a relatively large area, for instance, showing generalized thinning from a branch vein occlusion, or provide slice-by-slice images of very localized pathologies. You can, of course, also alter the color to allow easier visualization, and if you want to image the choroid better, you can do it with enhanced depth imaging. As we saw in the last talk, many machines also now support OCT angiography to allow non-invasive visualization of the circulation. The other part of the multimodal imaging platform is ultrasound, of great use both in tumors to allow you to measure the size of the tumor and characterize its echogenicity, and also, of course, imaging the posterior segment in the setting of media opacities. So let's look at some examples. So here is a typical choroidal melanoma with multimodal imaging confirming the classic suspicious features of thickness, fluid, lipofuscin, and ultrasound hypoechogenicity. Some can be associated with a serous retinal detachment, which you can see in the lower right shows up very well on autofluorescence. And then you get some strange ones, such as this one, which is associated with a cyst, which you can visualize both on OCT and ultrasound. But that's typical choroidal melanoma. Here's another dark tumor with a lot of exudate around it, which is a little unusual, of course. And when you do autofluorescence, you find it's very dark, and there doesn't appear to be much autofluorescence. Then when you look at it on OCT, enhanced depth imaging, it's not really in the choroid either. And as opposed to that previous melanomas, this one's somewhat hyperechoic on B-scan. So this is not a choroidal melanoma, and luckily for us, by chance, some years later, we managed to get histology on this eye, thanks to another issue, and it confirmed it was not a melanoma, it's adenocarcinoma of the RPE. So here's another lump in the peripheral retina, as someone mentioned, well imaged with Optos. We do an OCT through it, and it shows a large pigment epithelial detachment, which of course suggests a peripheral exudative chorioretinopathy. And this was confirmed, multimodal imaging again, with shrinkage both on OCT and photos some 3 months later. And another case, this is Sjogren-Larsen syndrome with a crystalline maculopathy. And these crystalline deposits show up very well on autofluorescent on OCT, while the autofluorescence shows a much more generalized pathology. And this white choroidal tumor with subretinal fluid, you can see it's in the choroid, it's associated with subretinal fluid, but it's white. When you do multimodal imaging and you look at the ultrasound, it has obviously very hyper-echoic with an acoustic shadow, and quite clearly it's an osteoma. And thank you.
On being on time, and now Dr. Sobu, can you discuss?
Thank you for the. Thank you for the image. Thank you for lots of these images, sir. So my question would be that let's say there are patients. Let's say there's a patient of PCV that comes to you. Would you be doing the multimodal imaging? Let's say you do the OCT first, or do you go ahead in the first?
I should say that I'm a vitreoretinal surgeon and do ocular oncology. I don't do medical retina, I'm afraid.
I saw a lot of your autofluorescence and infrared imaging. What would be your, best indications for autofluorescence versus red-free or infrared imaging?
I do autofluorescence routinely on all my cases, which are tumours and vitreoretinal cases, but mainly talking about tumours. As for red-free, I don't use it very much.
Okay. Thank you very much. Now.